Okay.
Okay. Good morning, everybody. Good morning, Sundar, Tanveer, and Ashish. I'm Mr. Wattoo. I'm one of a breast surgeon. Thank you very much for giving me the chance to speak to you about this topic. I just want to share about the common surgical emergencies which we normally come across in the A&E everyday practice. So these are the two main things, which we're coming across A&E almost everyday practice. So one is the abscesses and one is the abdominal pain. I'll briefly touch both of these one by one. So abscesses, basically, what is the abscess? Abscess is collection of pus after infection anywhere. Can happen any part of the body, and the treatment is almost the same. So
sorry, Mr. Wattoo, would you mind putting it in the slide proper presentation, please?
can you
It's
see that?
not in half.
If you like click on a presentation, like in the below one, full screen.
So can you see now? I know.
We are seeing, but it is on a half. So
If you go all the way down to the right, there's a small icon which says slideshow.
So
Not the extreme right, but just on the bottom right to the left side, actually.
bottom
Bottom
so
right and to the left, the leftmost icon.
the leftmost this pause, share the video. Yeah. Can't you see that?
we are seeing. So if you go to the like PowerPoint below, there is like 76%. So if you go in a -1, there is.
So in PowerPoint, okay, so fine. So just make it bit.
No. If you go to your minus, there is another button near to minus. Yeah. If you click that one.
Yeah.
No. It is smaller. So if you click the next button, minus to next button.
On the right or left? This one?
Yeah,
yes.
that one.
Yeah, yes, that's one.
Yeah, that's one?
Yeah, it is live presented now.
Okay. So you can see now, yeah?
Yeah, it is in a larger screen now.
Okay, that's fine. So yeah, as I said that the treatment, if it's just the induration, obviously yes, this is the clinical judgment, and there is a erythema, redness, but there is no fluctuation. It means there is no real collection of pus there, and then you can treat it with appropriate antibiotics. So, but if on examination you can see that there is a swelling which is fluctuant, and there is erythema, and obviously the patient would be a bit unwell as well, a lot of pain, etc., then it will need to evacuate the pus, either under local anesthetic or under general anesthetic, depending upon. There is another way, which I always practice myself as well in our breast clinics. If you can aspirate the pus by a large bore cannula, and normally I use the size 14 cannula. So if it's easy to, the basic concept is to evacuate the pus, and that can be done, as I said, that either making incision under local anesthetic or general anesthetic, depending upon. Or if it's easy, then you can just aspirate the pus, and I normally go for that, if it's possible, and you can send the pus for culture sensitivity. You can give appropriate antibiotics, and obviously then the patient can be reviewed. Well, it's difficult for you guys, in any, but you can then refer to the appropriate specialty, like if it's a breast abscess, or if the abscess is on some other parts of the body, then you can. But that's the emergency treatment you can do. Aspiration first, if you can do. If you can do incision drainage under local anesthetic, again, that's a clinical judgment, and also with the consent of the patient, because some patients they are not happy, are not willing to go under anesthetic, even if the abscess is small one. Some people, some patients, they are brave, and they won't, but if it's appropriate, you can do it under local anesthetic. And under local anesthetic, obviously you have to clean the area, use the local anesthetic, ask the patient, whether they have the local anesthetic before, like going to the dentist, etc., because some of the people, they are allergic to, they have the reaction to the local anesthetic. So making sure it's safe to give the local anesthetic, and then use a smaller needle. I normally use a very tiny needle to inject all around, and then just make a incision in the middle. You make a cruciate incision, and then you can trim the edges to make the hole bit bigger, and drain all the pus, give a bit of wash with saline, and pack the wound, and do the dressing, and then they can have a dressing by the district nurse. Obviously, there are certain abscesses, like in perianal abscess, or in other sensitive areas where it's difficult to do under local anesthetic, or if the abscess is a fairly big one and that needs a proper incision drainage, obviously then the patient should be referred to the appropriate specialty, like the breast or general surgery. And in theater, obviously, first we have to consent the people's explaining all about. And the important thing is that you have to explain the patient that there is going to be open wound, or which is going to be needing the daily dressing, and that's going to take some time, because sometimes the patient, they have misconception, that we are closing the wound. Obviously, if there's any abscess, you can't close the wound, so you have to explain that to the patient, that the wound would be open and that will take some time to heal. And the other thing, you have to tell the patient that sometime they can come back. So, and then, nowadays what we do, if the patient is not septic, and they can wait till the next day, so we can categorize them as a golden patient. What the golden patient means, that we can do first thing in the morning. So we consent the patient and send them home with some painkiller and antibiotics, and the patient come in the morning. And before starting the other large emergency cases, we just do these small cases like abscesses as a golden patients, So this is a sort of a brief review of the abscesses and the treatment. Any question so far for the treatment of abscess, please? Sundar, Suraj, Tanveer. Any question?
No, so far so good. Thank you.
Okay, fine. So the next topic is the abdominal pain, which we come across all the time. So acute abdomen means the
Sorry
symptom.
to disturb you, Dr. Wattoo. It's the slide. Actually, we can see only half of it. I don't know what's going on actually.
All right. Okay.
It's not fitting in our screen.
You want me to do something more?
Could you do control minus, please?
Pardon?
If you do control minus, we'll see like how it will show up.
Minus.
Control minus in your keyboard, and we'll see if it syncs a little bit.
Minus the keyboard. Not very.
So if you hit the control, keep pressing control and press minus, the size will go down.
Where could be the minus I can find?
Well, on the top, basically above the inter.
Above and okay. Okay.
Not sorry.
Uh,
Sundar, you have another idea?
In my screen, is it not full? Because I'm seeing.
Oh, Dr. Suraj, in my screen, I can see the full slide.
I can see it might be. Sorry, continue then.
Yeah. I'm a bit confused whether I'm seeing or not. So,
okay.
yeah, I'm seeing full screen. So
So you want me to continue?
yeah,
It's the,
Okay.
it's my screen. Sorry about that. Sorry, go ahead.
That's fine. That's fine. Fine. So acute abdomen means abdominal symptoms that suggest a disease which definitely are possibly life-threatening and needs urgent treatment. Early diagnosis is very important. Delay could worsen the condition of the patient and it may lead to fatal outcome. So early diagnosis is very, very important. The plan of action, obviously, when we see a patient with abdominal pain, we all know, and from our medical student days, we know history, which is very important. And we all very familiar, taking the history about the pain, about the time of onset, mode of onset, and it's very important because that can give you a good clue, by knowing about the detail of the pain, concentrate on, please, about all these things, any site, radiation, referred pain, character of pain, what is the effect of the pressure on the pain, like if the patient is peritonitic, then putting a little pressure on the tummy, patient will jump, and that it is peritonitis. Again, the relation with the movement, is there any aggravating or any relieving factors? So a good detailed history of the character of the pain, onset of pain, etc., is very, very important and give a good clue making a diagnosis. Again, we have to, other symptoms which happens in the acute abdomen is the vomiting. Again, history about the vomiting, how is the character, frequency, quality, history of the bowel movements, history of the water work. In women's, we have to take the menstrual history as well. All they can give us a good clue about a few of our diagnosis. Then obviously examination is again all basics, general physical examination, what is the general appearance of the patient, how the patient look like, attitude, pulse, respiration. Same we all do every day, and you are more experienced than me regarding this because you're doing this every day, abdominal examination. The important thing which I stress is the exposure. We have to have a good exposure of the abdomen from the mid chest down to mid thighs. Patient should be in a supine position. There should be a good light, and you have a good inspection of the abdomen regarding the movement or the silent abdomen. Again, if the abdomen is silent and patient is not moving it very appropriately, then it could be something going on there, and this is a sign of the acute abdomen if there is not good movement in the abdomen, because then patient must be in a lot of pain and he's resisting to breathe, and the movement of the abdomen would be silent. Other important thing, look for any hernias. Loads of time, small hernias can be missed, particularly in older ladies, and femoral hernias. It's so easy to miss and being caught in that scenario. So please look for all the hernial orifices, any umbilical hernia, inguinal hernia, and particularly femoral. Femoral is difficult to diagnose. They are small hernias. Just 1 minute, sorry. Ali. Yeah, yeah. Yeah, I'm in a meeting. I'll just be there in about 15-20 minutes. Yeah. Okay, thanks. Bye. Sorry for that. So yeah, hernias very important to look for, please, particularly the femoral hernias, and mainly in the older ladies, which can cause abdominal intestinal obstruction. So that's one. And then is the contour of the abdomen very important. Any distension, sometime one part of the abdomen is distended, when there is intra-abdominal mass, so the contour of abdomen is very important as well to find. In any visible peristalsis, in mechanical intestinal obstruction, particularly if the patient is thin and lean, you can see the visible peristalsis. Obviously, if the patient is a bit obese, then it's difficult, but certainly in thin lean patients, you can see the visible peristalsis, particularly in mechanical intestinal obstruction. Then look for any pulsating swellings, like aortic aneurysms. Again, it's difficult to see in a bigger patient, but you can see easily in a medium build or in a thin lean patients. Look for any skin changes, like in some of the people who are having a cirrhosis of liver, they have a particular signs, in very acute pancreatitis, you can see the signs on the skin as well. So it's a good inspection with good exposure and good light is important, and you can see quite a few things which can give you the clue to make a diagnosis. Then obviously is the palpation, percussion, auscultation, which we all do. Again, that they can help in making the diagnosis. Look for any bleeding PR, and in ladies, look for any bleeding per vaginum as well. Obviously with the chaperone and with the consent of the patient, if we are seeing a female patient, very important, although when you're busy in A&E and you can't find a chaperone, still I always advise and stress, that particularly the female patient will try our best to have a chaperone, not try to see by ourselves. Then the causes of the acute abdomen, which can be presented in A&E. So there are inflammatory causes. The common one are appendicitis. We all know about that, and again, when we do a history examination, then we can establish the diagnosis. Cholecystitis or biliary colic, pancreatitis, diverticulitis, salpingitis, regional ileitis, pneumococcal peritonitis, which we called primary peritonitis, when there is no other cause being identified, so sometime the pneumococcus can cause the peritonitis. Mesenteric lymphadenitis, particularly in younger people and in children, a lot of the children, they can present with the mesenteric lymphadenitis, and they can mimic like appendicitis. So we should be aware of that differential diagnosis in our mind as well. Meccals diverticulitis, again, the symptoms could be, the presentation could be like appendicitis, but we can come across the Meccals diverticulitis, which can happen in 2% of the peoples, and it gives the signs and symptoms similar like appendicitis. And the procedure is same, that we can do the Meccals diverticulectomy. Some people present with the source abscess, and they can present with the acute abdomen as well. So these are sort of the inflammatory differentials, and we can make it out by taking a good history and good examination, supported by appropriate investigation. Then we can reach to the diagnosis. The other causes of acute abdomen perforation, like perforated duodenal ulcer, sometimes the gallbladder, if it's acutely inflamed, and empyema of the gallbladder by the stone is stuck in the neck of the gallbladder, and the gallbladder can be perforated, and the release of all bile and pus, and can cause the acute abdomen. Diverticulitis, we come across every day, diverticular perforation after the diverticulitis, ulcerative colitis, and another differentials, which the patient can present. Then the obstruction, the obstruction can be caused within the lumen, like the tumors, they can cause the obstruction. Gallstones, sometimes the gallbladder is stuck to the duodenum, and there's a perforation, and the large stones can move from the gallbladder to the bowel, and that can cause the obstruction. So anything, sometimes big bolus, that can cause the obstruction. So anything within the lumen, can cause obstruction. Then in the wall, it's like, again, the strictures are the tumors, which can cause intestinal obstruction, and these are all the mechanical obstruction causes, and from outside the wall is like the bands, adherence, and internal herniation, or even strangulated femoral hernia, or strangulated inguinal hernia, or sometimes the knuckle of the bowel can be strangulated in the umbilical hernia as well, which can cause the mechanical obstruction. So again, good history, good examination, supported by appropriate investigation, we can reach the diagnosis. Hemorrhagic causes of the acute abdomen, like the rupture of ectopic pregnancy, ruptured of the ovarian cyst, particularly if ruptured on the right side, then the symptoms look similar to the appendicitis. And normally, if we're not reaching to the diagnosis, we do the diagnostic laparoscopy, and we can find some ruptured ovarian cyst, which can give the acute symptoms of acute abdomen. Ruptured AAA, there's sometimes very catchy, sometimes the patients present with the, not in the, pain in the front, they present with the pain in the back or pain in the flanks. So we should not dismiss the pain in the back or flank as a minor thing. That's a major thing. And again, history examination and urgent CT scan can give us help, When I'll share you with the case of this of the week, I'll tell you about the presentation of that chap as well. So ruptured aortic aneurysm is another very acute emergency, and don't forget about the pain in the back, or the pain radiating to the back, or the pain in the flanks. It can be caused by ruptured aortic aneurysm, because the blood is seeping retroperitoneally on the back, and that's why it can give the pain in the back. Ruptured spleen, sometimes there is a splenomegaly, and when the spleen is quite large size, it can rupture and give the bleeding, and that can be presented as an acute abdomen. Then there is a torsion of the pedicles, which can give the symptoms of acute abdomen. Sometimes the ovarian cysts, they have the pedicles, and that can be twisted and torted, and the symptom of acute abdomen can be found. And it's difficult on the clinical examination to diagnose the torsion of the ovarian cyst, but certainly with the appropriate investigation, and if not, then we can do the diagnostic laparoscopy, and we can reach to the diagnosis. Sometimes the spleen has got a bit longer pedicle and hilum, and then it's a bit more mobile, and that can be twisted and obviously present with acute abdomen. Then there are colicky causes, and the most common which we come across is the biliary colic or renal colic, due to the stones in the gallbladder and the stones in the kidneys, which can be moved to the ducts, and they can cause the colicky pain. Appendicular colic, another important thing, sometimes the appendix is not inflamed, but there are small ficolets, from the cecum, they can go inside the appendix and give a colicky pain. And the symptom is obviously having a colicky pain in the right iliac fossa, and this pain comes and goes, so not acute appendicitis, but appendicular colic can present as a acute abdomen as well. And intestinal obstruction, particularly when it's a partial obstruction, that can give that severe colicky pain as well. So there are some extra abdominal causes which can give the symptoms of acute abdomen, and they are the rare one, but still we can come across that sort of thing, like diaphragmatic pleurisy can give abdominal pain. Lobar pneumonia sometimes can be presented, and particularly when it is a lower right lung is involved, so the symptoms can be misdiagnosed or mismatched with the cholecystitis or biliary colic, So lobar pneumonia should be kept in mind, particularly when the patient presents with the pain in the right upper quadrant of the abdomen, or even on the left side as well. Pericarditis can sometimes be presented with abdominal pain, and not the last but least, but myocardial infarction can also be sometimes presented with the vomiting and abdominal pain. So that can be a very challenging thing as well. So these are the different differential diagnosis regarding the abdominal pain. Obviously, each topic has a very detailed, discussion and presentation and investigation, and the treatment. We don't have enough time. I just touched upon, that how the people can present in A&E with abdominal pain. Certainly, we all know about the basics, appropriate investigation depending upon the age and depending upon the presentation of the patient. Obviously, we all do a routine blood test, and then making our differential diagnosis, and based on the differential diagnosis, we can request any imaging, which includes a plain X-rays or any CT scan or ultrasound scan, etc. So thank you very much. If any question regarding the acute abdomen, I'm more than happy to answer if I can. Sundar?
So if we don't have any questions, so
then I can talk about briefly that the case of the week, and then I can finish my presentation. Yeah.
I think nobody has any questions.
Okay.
Can proceed to case of the week.
Okay, so that's very interesting case. I don't have the slides of that one. I'll just briefly tell you about the story of that. He was a 19 years old young man. In the past, he has got the background of sacral agencies, and obviously there was some bladder malformation. So he had some cystoplasty and a suprapubic catheter, but no other illness, and he was not on any medication. That's the background, living with his partner. Presented in Basarla A&E, very unwell, septic, dehydrated, and complaining of pain in the back for 2 days duration. and the urine in the bag was looking a bit cloudy because he was having this suprapubic catheter, and that was looking a bit cloudy. Temperature was normal, very tachycardia. Pulse was 156, maintaining the blood pressure at that time, but looking a sort of very septic picture, So taking the history by our A&E colleague, examining, and considering that having suprapubic catheter and a bit of cloudy urine, so the diagnosis of urosepsis was made, and he was started on antibiotics. And but when they did the blood gases, he was very acidotic, and the pH was 7.07, lactate was 6.5. And he was hyperkalemic. The potassium was 6.5 and hyponatremic. So it's a very bizarre picture, and obviously he was a young man, and feeling very, very unwell. And the only presentation that when I was talking the acute abdomen, he was not complaining of abdominal pain. He was complaining pain in the back for 2 days. He was also having a history of chronic constipation because of this sacral agencies. There was some nerve problem, and he was having chronic constipation, and he was on laxative medication for that. Anyway, so but they did all that in A&E, resuscitated. He was not getting better. The intensive care unit team was involved, and the medical team was involved, and a diagnosis of urosepsis was made, and he was transferred to intensive care unit. In the intensive care unit, he was treated and resuscitated, not getting better. The next day, a surgeon was involved, and again, because there was not much coming up with the history and the examination, so a CT scan was done. And apparently CT scan did not show any signs of acute abdomen. There was no perforation, there was no free fluid, nothing. The only thing was that there was a severe constipation, and there's a fecal impaction. On PR examination, there was hard stools in the rectum, and the surgeons tried to evacuate the rectum and remove some of the hard feces, but not all. With all that resuscitation, it was not getting better. So it was thought that there is something going on which is not going to be picked up on any investigation. So a decision was made that to be taken to the theater, and the emergency laparotomy was performed there. Normally, we don't do any emergency laparotomies in Basra, but this young patient was so sick, and he was not transferable to Doncaster. So we have to do the laparotomy there in Basra Hospital. And when the abdomen was opened, his sigmoid colon was all gangrenous, and from mid-transverse colon down to distal sigmoid, and there was necrotic patches on the right colon as well. So a subtotal colectomy was done with ileostomy, and the cause of that gangrenous bowel and these necrotic patches were a very, very severe constipation. So the patient was in ITU and getting better, but see, the chronic constipation can cause the acute abdomen as well. And it is a case of weak, because in spite of all these investigation, we couldn't really find any definite cause. And finally a laparotomy was done, and laparotomy was it can be as a diagnostic as well. So in this case, because it was not getting better with all the extensive resuscitation and treatment, and laparotomy found that he's got this gangrenous bowel, and that's why the source of sepsis was there, and he was not getting better. So that's a good lesson, that we have to, when we're making differential, that we have to be a bit open-minded. He has a background of sacral agencies, he was having a problem with this nerve supply, and he was previously having a chronic constipation. So that thing should be kept in mind as well. Sometimes the chronic constipation can cause a severe bowel problem as well. So that's the case of weak.
Okay. Yeah,
Any question regarding that?
That was intriguing,
Sorry,
Mr.
Mr. Wattoo.
Wattoo. Thanks for sharing that. I was just wondering, in terms of, we define that as a, like, yes, it's a severe constipation. That's why I could have, but there has been a lot of blood supply and everything. Had this histology come back at all to find out whether there was any toxic megacolon or something like that?
No. It's because, sometime, when there is a chronic constipation and hard stools, putting the pressure in the walls, there are small vessels in the wall of the bowel. And this severe pressure, compromised the blood supply locally, and that's why, we are still waiting for histology. But that's what I'm saying, that, but it was definitely due to, that severe constipation,
Thanks, Mr. Wattoo. So the problem in a case like this is somebody known to have severe constipation.
Pardon?
But somebody known to have regular constipation.
Yeah.
When they come to A&E,
yeah,
we can't be doing CT for them every time they come.
No. That's
in
again,
this case.
Yeah.
Was there the lactate very high? Was the lactate very high that could have made us think of
Absolutely. So because the bowel ischemia can give you acidosis, and yes. if you take the whole case into picture, obviously if somebody is just a constipation, and the rest of his blood and everything is normal, then obviously it's not a worrying thing. But if there is a acidosis, there is the lactate is very high, tachycardia. So it was a very bizarre picture, which is not simply fitting into just one thing, So in that case, the lesson for all of us is that we should see the case as a whole. Obviously, if there is something which is not fitting into, then that brings the bells, and then we have to start thinking some other diagnosis as well. In this patient, obviously he was very unwell, dehydrated, acidotic, tachycardic, not responding to any resuscitation. It means the source of infection or source of the problem is still there, which we are not reaching, and even the CT scan didn't show anything acute, It was, because it was not getting better. And when we did this laparotomy, we found out that he's got gangrenous bowel because of this severe long-standing constipation.
Right. What I am wondering is basically he has had a significant surgery for his cystoplasty.
Yeah.
Could that not have led to adhesion and which could have caused the problem? Did you see anything externally in terms of like any wrapping around the bowels or anything that caused that obstruction at all?
No. It was purely chronic constipation. It was not anything else. And there are patches, gangrenous patches, where there is a hard stool pressing against the bowel wall. There are that gangrenous patches you can see.
It's quite
interesting case.
Interesting case you had. The only thing is like the diagnostic dilemma, even after getting a CT scan, is quite shocking.
It is. That's what I'm saying. That's what I'm sharing with you. That in spite of doing all that investigation, if you're not reaching to the diagnosis and obviously the patient is not improving, then we have to think like this. In this case, young man, when there was nothing working, then yes, open the tummy, and he was not even fit enough to be transferred. Normally we don't do any major surgery, emergency surgery in Basila, but in his case we have to do. And the reason is this the same, because he was so unwell, and we know that it's not simply because of the urosepsis, because no antibiotics were working. So we have to do the laparotomy, and that's where we found out, the source of and gangrenous bowel can, very, very, very horrendous, can kill the people easily. So when we are making a differential, so we have to just be open-minded, one thing. And obviously, second thing is that if one thing is not fitting, and one thing is not working, then we have to think a second differential. And it is again multidisciplinary, obviously one person cannot handle all the things, so we all as a team, in a multidisciplinary fashion, we have to look after the patient, Okay. Any question?
I just wonder if this would have happened in A&E and the surgical registrar would have refused that time. It would have been a bit bizarre kind of situation, because this has happened in ITU and there was nothing much they could do. That's why the surgical line was actually asked for help. So that is when, surgeons, they do have to get involved. But what I feel, with what the presentation was, even if we had like a suspicion of surgical condition,
Yeah, we lost your voice, Suraj.
Yes. Hello. Yeah, sometimes the surgical team, even they distantly, like after seeing the CT scan, which is like requested from the A&E, they sometimes see the CT report from there and say, it is constipation, and you can send the patient home.
No,
like
that's what I'm trying to say, Jessica, that we have to take the whole case into the picture, obviously, but that's why I'm sharing this case, that's a lesson for all of us, So we can't dismiss, so a young man with having all these symptoms, you can't simply dismiss, and even the surgeon, they can't dismiss, and that's the example, that's why I'm giving you that example, that you can easily tell the people, that can happen. A 19 years old young man, constipation can do that. So that's the reason of sharing all that, that obviously if all the observations are fine, in bloods are fine, and then the CT scan is showing constipation, fair enough. But if he's a severely acidotic, he's hyperkalemic, hyponatremic, he's dehydrated, he's tachycardic, nobody can dismiss that case.
But that is after some time, no?
No, it was straight away. It was straight away. That's what I'm saying, that's a presentation in A&E. And he was saying that he's having pain in the back. And the person saw in A&E maybe thinking that having a pyelonephritis and urosepsis because complaining of the pain in the back. So he was having suprapubic catheter and having a bit of cloudy urine. And the person was making the diagnosis, and rightly, that because he's got a complex bladder surgery, and the suprapubic catheter can give the infection, which can obviously go up, and give the infection to the kidneys as well. So that was the presentation and the diagnosis made in A&E. But what I'm saying, obviously, again, the very good thing, involved the intensive care team, they involved the medics as well. Patient was admitted in the intensive care unit. So it was not that the patient was discharged or dismissed or anything like that. So we have to see everything in context, and if even one thing is suggesting that there is something going on, then, you put your foot down and say no. And surgeon cannot dismiss these things,
Okay, thank you.
right. Mr. Wattoo, just wondering, what was your palpation finding like in this chap?
Well, I didn't examine myself, but apparently what I got it that on abdominal examination, it was fine. There was no real problem. And that's why even when the surgeon, my colleague examined, he was not suspecting anything acute. And that's why they did a CT scan, again, came back fine. So I think the patient maybe sometime, if the patient is so unwell, it's very difficult as well to elicit all the findings as well, so there was nothing much on abdominal examination, maybe the patient was so unwell.
Yeah,
But good thing is that finally you got the diagnosis and patient got the treatment. That's the main important part of it.
Yeah, young man, so yeah, so we have to be a bit open-minded, and we should not dismissing anything, till we are sure that everything's fine.
Yeah, a very interesting case.
Yeah. So thank you very much, all of you. It's a pleasure for me to talk to you all my nice colleagues. So I have to now go. I have to see a patient. But thank you very much, and speak to you again about some other topics. Yeah.
Thank you.
Thank you very much, Mr. Atul.
Thank
Thank you, sir.
you.
So Sundar, I would be very grateful if you kindly issue me the certificate. I'm submitting my application maybe today or tomorrow, so I'll be very grateful.
Yeah, I'll ask you also.
Thank you very much. And if you kindly all give me the feedback as well, I'll be very grateful. Thank you so much.
Thank you.
Okay, then. Thank you. Bye-bye. Bye-bye.
Thank you. Thank you. Thank you, Mr.
Thank
Atul.
you.
Thanks so much.
So now we have a next presentation by Prajwal Dhungana. So if we are ready, we can start our next session.
Sure. Let me share my screen.
So